Thank you very much for that very kind introduction. My slides are not in 8 font. Unbelievable. I was sitting by myself in the specialist table that I've set up nicely in the front here. I'm obviously incredibly honored to be invited to a primary care research conference of this magnitude and of this importance. I'm an endocrinologist. I'm sorry. And then on this slide, you'll see my Twitter account. So who's on Twitter? Yeah, so tweet away. And there's also my email, which is the equivalent of electronic suicide. If you feel like there's a question or concern or something that was not clear, or you just want to follow up, drop me a note. There's an out of office waiting for you. This is I'm the only endocrinologist that can put this slide up. It's true. About 10 years ago, when we started our research group, we were focused on doing work to advance or to improve how we make decisions, and we thought, we can't have an alternative explanation for our work. In other words, it has to be in the patient's best interest. It has to be the best research evidence. It cannot be, oh, by the way, you're funded by this, or you were funded by X, Y, or Z, and that might explain why you're making. So we basically said no funding from any for-profit organization ever, and it's been very tough to stay there. But it's sometimes it's helpful when you commit in public to these things, because when temptations do come up, others remind you of your commitment. So that's been helpful. I feel a little tethered to this podium. I'm sorry. The microphone's here, although I notice it has no wires, so I'm going to move. This graph is actually among the most important graphs in healthcare. Sorry about the camera, guys. I just noticed that I moved out of your angle. I apologize. I'll be your nightmare. I'm going to start moving around. These graphs are important because they give you, and by the way, I didn't show my objectives or any of that because they're published in the book, but I want to say that I'm not going to talk about research methods. I'm going to talk about some research ideas. Sometimes we have the methods, but we're just, where do I take my research next? And I'm going to try to offer you a number of different places where you could go, recognizing that in this very audience are some of the experts in this direction. So if you just look at the rest of the if something inspires you here, then look at your program and you'll identify, likely within this same family, mentors that can help you in that journey. So that's my hidden curriculum. And this slide is one of those places where you can find ideas. That triangle is a triangle of all of research. Now, the base underestimates the real size of that base, and that is the base of all the research that does not matter. That is done because we're advancing knowledge, that is done because I'm curious, but it has very little to no implications to you or your patients. And it's only the tip of that triangle that is worth knowing and translating into practice. And the challenge for the frontline people is to know, what is that tip? What is that signal over all that noise? Once we are aware of that signal, then the next challenge is to find it acceptable and applicable. And that has been historically the challenge of evidence-based medicine, the validity, the applicability of the evidence. Even if you find the evidence and you're aware of it and you find it acceptable and applicable, then the next challenge is to have the resources to apply that evidence into practice, to be able to use that evidence, and then you have to act on it with the right patient at the right time. The purview usually of quality improvement. Now, most people stop there. If you have evidence-based medicine and you have a system that delivers it, you're good, you're done. But, and this talk has a flavor of chronic disease all over it. With most of chronic disease, the problem does not stop there, because for our treatments, for our approaches to be efficacious, we need the last bit, which is that patients have to agree with the course of action and stick to it. And that means that if you're going to effectively translate evidence into practice, you cannot do that without the patient. So think about that. One example of when patients don't sort of come along is the extent to which they follow up on our advice and they stick to our advice. And as you can see, if you look 50 years plus in the literature, about half of our patients don't follow our advice. That has economic implications that have been estimated in the billions in terms of avoidable hospitalizations and costs from side effects and challenges regarding treatment, but it also has implications for poor health outcomes. The implication I care the most in terms of non-adherence or non-compliance is what it does to the patient-clinician relationship. Because I work in Minnesota, I work in Rochester, Minnesota, -1 degree Fahrenheit when I left yesterday morning. Why do I work there? Okay, let's move on. In Minnesota, we're all very nice. And my patient comes in and says, yeah, I'm going to diet and I'll exercise. I'm a diabetes doctor, so all my appointments are about diet and exercise and promises of diet and exercise. And I look at the patient and say, yeah, okay, great, I'll see you in 3 months. And then the patient comes back in 3 months, they walk in, they look exactly like they looked 3 months ago. And it's like, how was it? I did it on Monday, but by Tuesday, struggling. But I've been doing it. I know that they're not, that they're not doing what they said they would do, and they know that I know that they're not doing it, and I know that they know that I know that they're not doing it. But they're not going to tell me, and I'm not going to confront them because we're nice. And but we have this gap now in trust that begins to, I can't tell my doctor this because my doctor is going to get angry, and I'm not going to tell the patient because I don't want the patient to run away. And we have now this gap between us that limits our ability to work together and to get good outcomes. So it complicates the patient-clinician relationship. The number one answer to the issue of patients don't ... is let's educate the patient, right? That the reason why people don't do what we tell them to do is because they're ignorant. And so there's a lot of effort to educate, despite the fact that when you look at the evidence of educating, you get little impact from educating in the traditional ways. But education does correlate with adherence. And this is the work that my colleague Devin Mann did when he was in New York. And this is Spanish Harlem patients with diabetes, in which he asked them, tell me about what you understand about diabetes. Do you think it's a big deal? Do you think it's a non-entity? Tell me about what you think about diabetes treatments. Do you think they're lethal or do you think they're helpful? And he then classified their answers, as you can see on the slide, in between people that were skeptical, in other words, diabetes not a big deal, treatment's very toxic, all the way to accepting, diabetes big deal, treatment very helpful. And you can see there's a nice correlation with non-adherence, but it's not perfect and it's not complete, but it's pretty good. The new Cochrane review on non-adherence or adherence interventions just came out yesterday, and it confirms, again, 50 years of research that educating patients about disease and treatment is not sufficient to improve their adherence, at least to medication. So it's interesting correlation, does not point in the direction of solution. Another thing that does not work is to yell at the patient. We use it with foreigners, right? When we are, when they cannot understand what we're saying, we just raise our voice and speak slower. They still can't understand what we're saying, but we somehow feel that we're helping. In the case of our patients, we threaten them. I mean, I'm a diabetes doctor. Favorite phrase: if you don't do what I'm telling you to do, we're going to have to, that little pinky went to the market and didn't come back, And we're going to threaten them with blindness and transplants and dialysis, and doesn't work. If you go to any kind of forum online where patients talk to each other, you will see many patients saying, it's been 8 months since I've gotten my A1C, I have type 1 diabetes, but I don't want to get it because if I get it, my doctor will see it and then he'll chew me up. And so I'd rather avoid medical care rather than being chewed up by my doctor. So this phrase from Brian Haynes, who's led most of the important adherence work over the last, I was in a bus with him in Taiwan 2 weeks ago, and he said, in 1972, I did a clinical trial. I was 2 years old when he did a clinical trial in 1972. So he's been around for a long time, and it's that this had to be printed in JAMA is actually quite telling about how we deal with non-adherence as a profession. I'm going to show you a different way of thinking about this problem that I find very compelling, and I hope that you'll find elements that are attractive. And I'm going to introduce you to John. I've been showing John around for probably 4 years now. So one of the things I learned is that you have, in order to make an impact, you have to repeat again and again and again the same thing. So some people in this audience have met John before, just for fun. How many of you have seen John before? One. All right, so I'm sorry. You'll see John again, return visit. So John is a patient I made up. And then he showed up in my practice, and kind of like a Victor Frankenstein moment. And I'm sure if you have any clinical practice, you would have met John. Or John may be your crazy uncle that shows up on Thanksgiving dinner or something. But you'll know John. John is 55 years old. He has diabetes. He's on metformin and glipizide. He also has hypertension. He's been on a beta blocker, hydrochlorothiazide, and that was not sufficient to achieve the target blood pressure measures for quality. So his doctor promptly added a beta blocker. Now, every time John stands up really quickly, he gets dizzy. He has high cholesterol. He has depression. He also has a bad back that hurts. He has pain in his feet from neuropathy. He is obese. His doctor has told him it's time to go and see an endocrinologist, always a good idea, see a podiatrist for his feet. He has to see a dietitian. For that, he has to go to the big medical center, so he'll have to take some time off work, find someone to give him a ride. When he gets there, he's going to be told that he needs to quit the salt, quit the fats, quit the carbs. He's going to be told to exercise, which, of course, is very challenging given his bad back. He'll be told to check his feet, but John has a big belly. I mean, he hasn't been in contact with his feet for a long time. He'll be told to take pills, but of course he's taking his pills. Otherwise, how is he getting dizzy, right? He'll be told to check his sugars, which he checks. He writes them down in a book, brings him to the doctor's office. The doctor reviews a little booklet with all the numbers, gets a breeze on his face as he's moving through them, and then looks at that hemoglobin A1C as the only thing that matters. And it's 8.2%, and it's high. His LDL cholesterol is high. His weight is also high and parked at 108 kilograms. That's for our Canadian colleagues. And this is really what they're talking about. He's also in pain and he can't sleep, but that doesn't come up in those conversations. The reason he can't sleep is that he used to be in a company where there were 3 accountants, then 2, and now he is the only one in that capacity. The deadline is always now. He has to perform. He's bringing the work home and he's looking at things carefully and he's realizing that these numbers are not adding up and this company is going under, and he's going to have some difficulty with his financial obligations, insurance, debt, and mortgage. The thing that bothers him the most about the home is not the mortgage, is the fact that his older daughter has come back to live with them and has brought with her 2 beautiful granddaughters. And the reason they've moved in is because she was in an abusive relationship with her husband, and they were doing drugs and alcohol, and she's always wasted. As he's reflecting on the situation, the future of his grandkids, he opens up the mail, and he gets a note from his primary care doctor, from his primary care office, indicating that because he's not achieving the goals, the targets of control for chronic disease, he needs to look for another primary care physician. So what's up with John? Is he not taking personal responsibility? Do we need to educate him? So I would put forward that the problem with John is that he has a complex life, he has a complex context, and the healthcare program that he has does not fit. And any reasonable clinician would want to collaborate with John to come up with a program, to co-create a program that fits. But we don't live in that world anymore. We live in a world in which the only acceptable answer to the situation of John with a high A1C and a high blood pressure and a high cholesterol and a weight is to intensify the treatment. If we don't intensify the treatment, we are told we have clinical inertia. because we are not intensifying the treatment. Am I crazy? Well, this is a survey of primary care clinicians. It's getting old, may need to be updated. But the most striking one, I mean, all of these items are striking, but look at the last one. A third of primary care clinicians think that their own practice is too aggressive, more aggressive than they would like it to be. When I show it to primary care clinicians, I'm looking for nods. People go, when I show it to patients, there's panic. Because you see, patients realize they're not in charge. But they thought their doctors were. But the doctors are saying they're not in charge. So who is in charge? So one of the ways of explaining this is to look at our evidence-based guidelines. And as you know, we have evidence-based guidelines that are disease-specific. We have guidelines for diabetes, guidelines for type 1 diabetes, for type 2 diabetes, for diabetic nephropathy, for diabetic retinopathy of the right eye and of the left eye. And we have very narrow, if there's a society of the right eye, there'll be a guideline for the management of diabetic retinopathy of the right eye by that society that you should know about. And there will be a quality metric associated with it and some certification that somebody will hold you accountable to. So what about these guidelines? Well, several problems with this guideline. One family of problems is the problem of, by being focused on one disease, they should be thinking about the issue of comorbidity, but they don't. And this issue of comorbidity needs to be explored in detail. I find this very helpful, very easy. It was published by my colleague Scott Richardson, and he thought that there would be three areas in which comorbidity might matter. One is this issue of baseline risk, right? So in this particular case, the patient has diabetes, has hypertension, and has hyperlipidemia, and that will affect the patient's baseline risk of coronary disease or nephropathy or retinopathy. So the comorbidities affect the baseline risk. Then there is the responsiveness to different treatments, in which the fact that we, for instance, start an antidepressant or manage the depression when we're trying to achieve glycemic control might make our glycemic control intervention more efficacious than if we try to do the diabetes treatment alone. So the responsiveness also changes with the comorbidity. And then there is the vulnerability to side effects. So this patient has neuropathy and is taking antihypertensives, and if he takes a Neurontin or gabapentin sort of medicine that has a side effect, dizziness, this person is going to have a significant problem with the side effect of dizziness. So when you're writing a guideline, you will say, well, it's impossible to take into account all these comorbidities, but if you don't take them into account at some point, you run the problem of irrelevancy. And I think that's one of the problems with the guidelines. We did a study of diabetes guidelines, and this is a kind of one of those radar diagrams showing the proportion of guidelines that address different comorbidities across different, marquee recommendations. And the one that the guideline developers paid least attention to adjust for comorbidities was blood glucose monitoring. So if the patient has tremor or Parkinson's or can't see, doesn't matter. The blood glucose monitoring should be done, self-monitoring should be done. So no adjustment there. They did a good job with aspirin. And you can easily imagine, a guideline that reads something like, if the patient has allergy to aspirin, nasal polyps, or is on anticoagulants, you may want to hold off on the aspirin, right? So they're suggesting some account of the comorbidities. But this is how much the guidelines took into consideration other aspects of the patient context. In this case, social and personal aspects. Nah. How about patient preferences? Forget about it. Right? So the guidelines are not only disease-specific, but they're context-blind. And that shouldn't be a problem because the guidelines guys are assuming that the frontline clinicians can do the flexing, right? I'll take the guideline and do the adjustment to each individual patient. But then people come in, take the guideline and make them into quality measures. And then they hold you accountable to the quality measures and the flexibility is gone. Sort of unintended consequences. So then you have this care coordination, medical home things, where you try to do all of these at the same time to the same patient. And what you end up with is these incredibly complex treatment programs, and you recognize they're probably not safe. So you add incredibly complex monitoring schemes and visits to try to keep it safe. And then, this care coordination you're doing is really without any prioritization. So it's just adding more and more and more, trying to get patients to do more and more and more and more. And we did do this shift of self-management, which is just, you need to do more of the work that we used to do for you. And then eventually, this means that their treatment burden that the patient will have to face is just going up, and patients and caregivers is just going up. And then eventually, people can no longer cope. And so what will they do? Well, what they do is they pick and choose what to do. And then when they don't do what you like them to do, they're non-compliant. They're non-adherent. It's their fault. Let's educate them, or threaten them with an amputation. So at the top, I left some space because there's a macro picture here. We are creating more and more chronic diseases. Did I mention that I'm a diabetes doctor? And not enough with diabetes. We need to make sure there's also pre-diabetes. And of course, if you have pre-diabetes, you got to treat them just like if they had diabetes, just a little earlier. That's a good idea, right? I mean, Mrs. Jones, you have pre-diabetes. Oh, my God. Don't worry. I have the treatment for you. Yes, you can exercise and stuff, but we've established you don't do any of that stuff. So I'll give you metformin. Oh, great, doctor. What does this drug do? We don't really know, but it's good. But it will reduce your chances of getting diabetes. Oh, that's wonderful. It reduces your chances of getting diabetes by 50% at 3 years. Oh, wonderful, wonderful. So, doctor, what happens if I do get diabetes? What will you do for me? Well, I'll start metformin. So you're going to give me metformin now to reduce my chances of needing metformin by 50%. Brilliant. I'm not entirely sure how those conversations actually go, but I suspect that they don't go like that. And then there is, of course, the promotion of treatments. I mean, you cannot have someone in the office with a condition that you can diagnose and do nothing. We're all geared up to do something. So I think this at the macro level, this further contributes to the problem. So we have these evidence-based guidelines, these quality measures, and this specialist care that we glorify. And all of them fail at the context level. And as I said, by poor coordination and shift to self-management lead to overwhelming situation of increased treatment burden. This model is helpful to you, and you might want to consider it as you explore the problems that you're interested in. And it looks at the workload and capacity balance to the left of the model. In a patient that has enough capacity to do the work of being a patient, they'll be able to access care, use that care, and enact the self-care that's necessary to achieve the outcomes that they want. If that care is evidence-based and effective, the outcomes will be better. If the outcomes are better, then maybe somebody may cut back a little bit on the treatments that are necessary because patients are better off, but usually that doesn't happen. And then the burden of illness may decline, so people will feel better. If they feel better, they have more capacity. And ideally, we don't want people to have more capacity so they can do more patient work. We want them to have more capacity so they can pursue their life hopes and dreams. So what I've pointed out before has been this burden of treatment that comes through this approach that I mentioned. But notice that the capacity that patients have is the same capacity that they use for the work of being a patient, is the same capacity they use for the work of life. And turns out life is a lot more inspiring than the work of being a patient. And so as a result, when we give someone something to do, we're competing with life for that work to get done. I have 3 boys, and I asked them, what do you want to do when you grow up? Not one of them has told me, I want to be a great patient. And notice that capacity is not only reduced by illness, by just any general form of scarcity. And I'll get back to this in a few minutes. What is this work of being a patient? Another area of research is just waiting for somebody brilliant to uncover it. Katie Gallagher is here in the audience, and she's done this work, but it's early days, and others need to join. This is based on the normalization process theory. What is the work of being a patient? Sense-making. This is why your patients Google stuff. This is why your patients look into the package insert and read that the reason The reason you gave them the medication is one of the side effects of the medication, and then that's why they want to stop it. This sense-making is important. If people don't understand why they're doing things, then they'll quit. This is all that education thing that we intuitively want to give patients. Patients with chronic disease have to organize themselves and have to enroll others. Look at that picture. The man on the left is, it's Sunday afternoon, and he just got summoned by his wife to set up the pillbox for the week. And so you see the little pill containers, he's dropping them into the pillbox for the week. She's helping him do it. If it was up to him, he would not do it. Right? He would just take, of course, I can just take him from all the containers. I know what I'm taking. I know exactly what I'm taking. You know, so I was like, yeah, whatever. Let's put it in the pillbox. It's Sunday afternoon. But if you notice, I mean, particularly for those in the way back, she has on her left wrist, she has a medical alert bracelet. So this caregiver, if she gets sick, you know he's going to go back to taking the pills from the container, and he's going to go non-adherent. So it's critical to have the right help to get this done. Then do the work, show up for the visits, take the medicines, and then patients need to have some sort of way of knowing that all this work is worth doing. So they need to reflect, and they have to think about and appraise, is this worth doing? So how much do we do to help people understand that this work is worth doing? If they decide it's not worth doing, they'll stop doing it because they're busy. So we need to understand that better. This is a personal picture. That's my wife's forehead. It's not very, I mean, it's beautiful. This is a mirror from a hotel in the Caribbean. And why did I get invited to New York instead of Cancun? What was wrong with that? This is a hotel. This is a hotel in the Caribbean. You can see by the little conch shells on the edge of the mirror. On the way out, you know, we're planning this vacation. On the way to vacation, I have a son with ulcerative colitis, and he got complicated with C. diff, and so he tried the metronidazole. That didn't work. So the pediatrician said, "Oh, here is vancomycin, oral vancomycin 4 times a day. Have a great vacation." Like, how the heck are we going to do 4 times a day without pestering this kid, ruining his vacation, and us going completely crazy and making sure he's, sticking to the plan, right? And so, for days, the 2 or 3 days before the trip, my wife was brilliant, started thinking, how are we going to do? So she went all 5S lean on us and developed this system, which little envelopes, for the days and then for the 4 times. And this system obviously had 2 purposes. The kid just had to go to the bathroom, take the next envelope out, take what's inside, go back to the beach, play. And if we wanted to know if he had if he was adherent to the program, we just had to go to the bathroom and look at the mirror. And we could see that if he had been adherent to the program. We don't have to be going after each other and yelling and ruining the vacation. It worked beautifully. But I know the pediatrician had no idea how much work this will be. No idea. 4 times a day in the Caribbean. God almighty. Now, who is at most risk of being overwhelmed? People with multiple chronic conditions. The more diagnosis, the more likely they'll be overwhelmed. There'll be more work. We do not know how much time patients and caregivers spend taking care of health issues. This is a systematic review published in 2012. Estimates about 2 hours. Most of the data comes from diabetes. We do not, it's very weak data. We do not know much about the work of being a patient. Gosh, we should. We don't. We looked at our primary care visits. We looked at 46 primary care visits. We video recorded them, and we found 83 discussions about the work of being a patient in those visits. But unfortunately, 70% left this, and most of these were like, I'm overwhelmed with this work. 70% of those statements were left unaddressed. So obviously, we need some improvement there as well. So what about this capacity story? That's the work. What about this capacity? Well, the capacity to do the work means you need to have resilience and literacy and cognitive bandwidth to try to get all to work. We need to have mental health to execute anxiety, depression, well managed so we can execute. Physical health. If you have an orthopedic problem, you're going to be walking very slowly. That means in your day, you can only do 2 or 3 things. Right? Unless you have like a cane or a walker or a wheelchair or you get rehab. if you can't hear well, if your glasses are not adjusted, if your cataracts are not operated on, it just takes more effort and everything takes longer. Just like being poor takes more effort and everything takes longer. So you get to do fewer things in a day. You have lower capacity. If you're lonely, you cannot ask for help. It's pathetic when we ask patients, by Friday, could you come up with a friend that will help you with your dog, with your walking around the neighborhood, with your house while you're in the doctor can take you to that. Some people don't have anyone. Not anyone that will give them capacity. And there are community organizations that can provide plenty of capacity, and they complain they cannot reach their clients. And you have the patients waiting, with limited capacity, not having the capacity to reach out to these organizations. So it's social and environmental. Where I work, people live in the middle of, not even the internet has arrived, where they are, and because they're so deep in the middle of nowhere. And for them to access and to get things done, they have to get out of the house, get on the truck, and drive through the snow. That just takes time, it takes effort, and so it doesn't happen. So what do clinicians do when they see people like John? They might want to ask the question, is there a syndrome here? Instead of saying, it's non-compliant, which is, of course, completely unkind, if not inaccurate, we could say, is this possible that we have a syndrome here of an imbalance of workload and capacity? Two presentations of that syndrome. Life gets in the way of clinical care, or clinical care interrupts life. Is this acute or chronic? Very simple. Was this caused by increased work? And is this increased work coming from life, or is it coming from patienthood? And is this caused by reduced capacity? Which kind? Is it on the personal side, the literacy, the resilience? Is it mental health, physical health? Is it on the socioeconomic? So you have a differential diagnosis associated with this syndrome. So if you think about John, that you have a workload to capacity imbalance? Yeah. Is it from life-interrupting health care? Probably. That daughter, that granddaughter, that work situation, that's heavy on him. That's reducing his bandwidth. That's a reduction in capacity. So he has an increased workload from life and a reduced capacity from bandwidth, from mental health. He has unresolved depression, pain, and for physical health, pain and insomnia. Wow, that gives us a little direction here. We can help John if we could just improve his workload capacity imbalance. So how might we do that? We can assess the burden, like I just did very briefly. And then we can try to really reduce the work, or optimize the work to align it with the patient goals. And there's some strategies that there on the board. Medication therapy management is a promise. A review published last week suggests that we don't know enough about it, but the idea of de-prescribing is quite interesting, not just for older people. Capacity coaching, like health coaching, but looking at issues of capacity. And shared decision-making. I just want to briefly mention shared decision-making because that's been something that we've been doing over 10 years, and I just can't resist the opportunity to show this to you. It's been incredible work because we were told that it cannot happen. It's only for young people. Look at the average age of our population, where we've done this 65. It goes up to 95 now. When I did this slide, it was 92. We just had a 95-year-old. It can only happen when in specialist care, you have time. Well, we've been make it work in primary care. We've made it work in the emergency department. Clinicians don't want to do it. We got clinicians, 90+% clinicians, some of them, and some others 75%, but certainly a majority of clinicians interested in continuing to do shared decision-making with some tools that I'll show you in a minute. It takes too much time. At most 3 minutes in the consultation, you use the tool. You need a lot of training. We get fairly decent at fidelity to how it was designed with minimal training. And you only improve knowledge. Yeah, that's actually true. We improve knowledge, we improve participation. Oh, is it true that it reduces cost and improves outcomes and reduces world hunger and reduces global warming? No, shared decision-making does not do any of those things. And actually, we have not been able to demonstrate that it improves adherence. So why would you do shared decision-making? Because it's the right thing to do. And one of the most popular things that we've been able to put out is this Statin Choice decision aid, which is to help people decide whether they want a statin to reduce their cardiovascular risk. Gone are the days of, Mrs. Jones, your LDL cholesterol is 101 milligrams per deciliter. According to the guidelines, it should be less than 100 milligrams per deciliter. Ideally, 70 milligrams per deciliter. You should take atorvastatin 10 milligrams. I'm prescribing this to you. We'll come back in 3 months. If your LDL cholesterol is not under 100 or ideally less than 70 milligrams per deciliter, we'll increase the dose until your muscles hurt. And now with this, you can go, Mrs. Jones, you're in a room with 100 people like you. As you can see, 78 people after 10 years will not have had a heart attack, and 22 people in orange will have a heart attack. I do not know if you're one of the 78 or one of the 22. If we give a statin to all of you, all 100 of you, and wait 10 years to look, what we'll see is that the 78 that were not destined to have a heart attack took medicine with no benefit. Of the 22, 17 still had a heart attack despite taking the medicine regularly, and 5 people in blue avoided a heart attack because they took their medicine. Mrs. Jones, are you interested in taking a statin? And it's a conversation that goes in a number of very interesting directions, including the possibility of saying, well, I just rather die quickly. If I take a statin, will I die of cancer and dementia only? And then you have this tool, which is to help people with diabetes choose their diabetes agent. Gone are the days where the endocrinologists were the only ones who understood the pathophysiologic mechanism of diabetes and would tell you exactly what was insulin resistance, insulin sensitivity, and insulin sensitizers. And now the only difference between these drugs is how much they cost and how toxic they are. And the patients are the best judges of that, of how they want to be. So why not invite them into that conversation if they're going to be suffering the consequence of the decision? And my colleague Annie LeBlanc is presenting work here. Where's Annie? Wave. There it is, she is over there. She applied this exact same model to antidepressants, enabling primary care clinicians around the country to participate in making decisions about antidepressants that no longer focus on the one antidepressant I know and the one that I use when the first one doesn't work, which is the most common approach. People won't use this. This is data from July to September 2014 of the use of that Statin Choice decision aid. Light blue means it's used. This tool has been used in almost every country around the world in that period of time between July and September 2014, with the exception of Paraguay, Western Africa, Greenland, and Iceland. I know what's going on in Western Africa. I have no idea what's wrong in Greenland. But you can see that the United States is the #1 user of this tool, about 56,000 uses. This is a distribution of the use in North America, in the United States. We always draw Canada like a white space on the top, like it doesn't exist. A lot of Northwest use. Looks like Kaiser Permanente might be using it. This is a free tool, so we have no idea why or people use it or not use it, but it's obviously being used quite a bit. Minnesota, where I live, is that blue thing in the middle, close to that white space, and it's the most the highest user, but the highest use is not in Rochester, where we are, but in Duluth, way north, where clinicians have decided that this is the best way of delivering primary care, and all the users there are family docs. So that's apart from shared decision making and medication therapy management and capacity coaching, we can also do some referral actions carefully because referrals increase workload. But self-management training, palliative care for people that are not dying, mental health support, physical and occupational therapy now fits. Right, because you're trying to increase patients' capacity, financial and other resources in the community and governmental services. This idea that social determinants of health, that phrase that we use to say it's someone else's problem, you can bring it into the consultation and talk about the patient's capacity and try to solve this workload to capacity imbalance. What can we do at the system level? Well, we can start by respecting people and not making them wait forever. And respecting them when they call us, respecting them when they're at Mayo. We have a problem. If we have a great system, you can get your refill on the computer. You can mail it to me. Thank you. If you send that in, you get the prescription if it's sent within 10 days of when you should be running out. If you send it in day 11, they don't hold it until day 10. So until the next day, so that it will work. No. Call back again tomorrow, because tomorrow will be 10 days from your date. You follow that? I mean, it's like your time and your effort is not important to us, thank you for calling, right? Call back again tomorrow. Why can't you just write it down and hold it until tomorrow? Call us tomorrow. We need to train the primary care team in this language so they can communicate. Mrs. Jones has a capacity problem. We have a workload problem. We have an imbalance problem. It might actually improve the way we communicate within the team. And then we need to get these guidelines and the quality measures to begin to address this issue of context before they go completely into irrelevancy. This that I just described is this idea of minimally disruptive medicine. My colleague Frances Merrick, who's in the audience too, where's Frances? Where are you? Oh, there she is, yeah, by the microphone. Talks about maximally supportive, minimally disruptive and maximally supportive healthcare. It's healthcare that pursues patient goals while minimizing the healthcare footprint on their lives. And how will we measure quality then? Well, we will have to have measures of this balance so we can hold each other accountable for the fact that we're managing to the patient's capacity and workload. We could have measures of satisfaction with the way we deliver our care so access and use of care might be effective and self-management be supported. And then we can look at outcomes that focus on function, focus on health, focus on the ability of people to pursue their hopes and dreams in addition to disease control. So it actually impacts also how we can hold each other accountable. And why does it all matter? Because this wave is moving from right to left. This is the wave of comorbidity, of multimorbidity, actually. And Martin Fortin, who is, or Martin Fortin, I just had to get this wrong, is in the audience and one of the leaders in this area as well as others here. So I don't have to say this, but we just got reproduced this in Olmsted County, which is where Mayo Clinic is. The average person, this is from Scotland, and we know people from Scotland are sort of, sick. Anyway, the average person in middle age has one chronic condition. The average person in middle age is no longer a healthy person. And this is moving from right to left. Now, you can see there that about a fourth has 2 or more chronic conditions. So when people say the aging of the population is going to be a problem, they think, there's going to be more older people. That's one part. The other part is that younger people are going to look like older people. And they're going to need the services that were previously focused on older people. For primary care, this is a huge challenge. So how might we deliver care for people like this that are going to become the majority, if not already the majority of the patients that knock on the door of primary care and not with an acute problem? And we have to respond by supporting their ability to adapt, because they're going to live with chronic disease, to adapt to that situation and self-manage. We'll have to work very hard to help them fully play the role they want to play in their lives and make healthcare fit. And I'm going to leave you with this image of the last canary in the coal mine, as I understand it, it's an English photograph. When we look at the issue of patient non-adherence and non-compliance, it's an opportunity to reflect on what kind of healthcare we are delivering. Is it careful, high quality, safe? Is it careful? And is it kind? And what if we, instead of every time we see a patient that's non-compliant, what if instead of blaming them and focusing on their shortcomings, we look at ourselves? If we had a canary in the coal mine, the canary breathes very quickly and accumulates all the toxins of the coal mine. And the canary is the first one to tell if the coal mine is getting toxic. And if the coal mine is getting toxic, the canary does not die. Interestingly enough, I guess eventually could, but interestingly enough, the canary gets restless in the cage, starts moving back and forth and gets restless, and then it stops singing. So what if the patient that stops coming to our visits, stops taking our medicine, stops following our advice, is alerting us that the coal mine has gotten toxic, that the healthcare, and these patients with chronic conditions touch healthcare in so many ways and such frequency that they're just like that canary in the coal mine, breathing faster than the humans. What if that patient that stops doing all that is telling us that healthcare is no longer meeting their needs, that it's time to change, that it's time for a patient revolution? And it is a task of this group to figure out the science in support of that revolution. Thank you very much for your attention.